abnormalities, prolonged intensive neonatal care, where there's a risk of subclottic stenosis, history of fever, nasal discharge, and any chronic steroid therapy or type 1 diabetes. Again, there's a mnemonic called AMPLE. We take an ample history. A for allergies, M for medications, P for any relevant past medical history, L for the last meal or the fluid which has been taken and the type of the meal, and any events which are leading to the anesthesia in the past. Now, this is how our pre-anesthetic evaluation looks. It's very exhaustive, and it is taken for all patients, including topical anesthesia cases in Nethradhama. Some special considerations are, like in neonates, you can have cataracts, and the precaution would be keeping the baby warm, glucose management, and monitoring for post-op apnea. Certain syndromes like mucopolysaccharidosis, which can come with cataract, corneal opacities, etc. We can have difficult airway and difficult intubation. Down syndrome is quite common, where they can come with cataract or strabismus. We may anticipate difficult intubation or cervical spine instability. Very important is ophthalmic drug history, especially the use of beta blockers in glaucoma, where we could have bradycardia refractory to atropine, Diamox in glaucoma, which can cause metabolic acidosis, electrolyte imbalances, any antimuscarinic like atropine, etc. You can have dry mucosa and tachy. Phenylephrine, which can cause hypertension and tachycardia perioperatively, and NSAIDs, which can potentially worsen or precipitate an acute asthmatic attack. Going on to the general examination, we have PICL, which is pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. The vitals, the airway assessment, the Wilson and the Lemon scores, the neck movements, and a thorough systemic examination. Well, I'm wondering whether we need to do any investigation after Dr. Edwin's talk, but I guess we still stick to a routine of a CBC hemogram and an RBS, and chest test X-ray when indicated, and neck X-rays when we anticipate any airway obstruction. 2D echo in patients with congenital cardiac anomalies, and a baseline SpO2 on room air when indicated. We do an ASA physical status classification, and most importantly, a written informed consent, which is adhering to the COP8E standard objective element, which is explained in the language which the patient understands, along with the benefits, outcomes, risks, and side effects of general anesthesia in the baby. This is how our written informed consent looks in Nethradhama. It has 2 pages, and we also have a special high-risk consent, which is taken depending on if the patient has any syndromes or any difficult airway management. We have a standard starvation protocol, 6-4-2, 6 for solids or milk, 4 hours for breastfed children, and 2 hours for clear fluids. In Bangalore, the incidence of asthma is very high. We have a lot of allergic bronchitis, hence I've just mentioned this. We need to ensure that the baby, we adhere to the medication regimen before surgery, and optimization perioperatively with nebulization and humidification. Any perioperative steroids if it's required, and emergence from anesthesia is the most vulnerable period, and judicious timing of extubation is very critical for successful outcomes. Again, according to Care of Patient 8C, we have to document an anesthetic plan for any form of surgery. So you have the type, the calculation of the doses, the intra-IV fluids that are based on the weight of the baby, the equipment required, the ventilatory parameters, and also there's awareness among the team regarding managing any potential complications. And this is how our anesthetic plan form looks. Again, we have another acronym called SOAP-ME before we start the general anesthesia. S for suction, O for oxygen, A for airway, P for the drugs, M for monitors, and E for all the necessary equipment. Well, we need a quiet, calm child in the preoperative room. Hence, we may require some form of pre-medication in the form of oral intranasal midazolam or syrup promethazine, triclophos or alprazolam. You can also require some anti-silogogues. It could be atropine, oral or intravenous. We could also have some moderate sedation in the form of fentanyl or midazolam combination. And now we have the dexmedetomidine IV infusion or nasal dexmed also available. This is the WHO surgical safety checklist. We have a sign-in protocol, a timeout which has to be announced before we start the general anesthetic, and a sign-out protocol. Coming to the intravenous fluid management, which is very, very important. It is divided into the fasting, the maintenance, and the fluid loss replacement. All children would need 2 ml per kg for the starvation period, a maintenance following the 4-to-1 rule, and a much simpler formula, less than 15, more than 15, 25 ml per kg and 15 ml per kg. Coming to the type of IV fluid in pediatrics, crystalloids form the mainstay. We can also use the balanced solutions like Plasma-Lite, which is very similar to the plasma. And do we need glucose in our IV fluid? It's not routinely required because stress of surgery in anesthesia induces a hyperglycemic status. But children with history of hypoglycemia, diabetic mothers, neonates require glucose to be administered. And hypoglycemic symptoms like jitteriness, lethargy are masked by general anesthesia. Hence, we can use a solution known as Isolite P, which has about 5 grams of dextrose in every 100 ml. Now, in the immediate preoperative, you must have heard in the NABH standards, they say that you need to document immediate preoperative status of the baby before giving the general anesthesia. So just before we start the general anesthetic, once the monitors are connected, we need to monitor the vital stats and document it. Along with that, proper intraoperative monitoring notes adhering to 8F in the eye care organization standards is very important in children. Temperature, the cardiac parameters, blood pressure, and the SpO2 and ETCO2 are very helpful. This is how our form looks when we give general anesthesia in Nethradhama. Coming to the induction, inhalation is suitable for the needle-phobic baby or those children with difficult venous access. Sevoflurane is the first choice of volatile agent. It's very pleasant to smell, non-irritating to the airways, and a rapid onset of action. If you decide to go for IV induction, you could use propofol or thio. Addition of atropine reduces the oculocardiac reflex incidence. Airway, now we have the supraglottic airway devices, the second generation ones are preferred. And it causes less laryngeal irritation, can be placed without visualization of the airway. Since in ophthalmology access is restricted, we need to secure the tube well. You can have a south-facing tube. And you should avoid endotracheal intubation in history of upper respiratory tract infections. The gas oxygen agent is satisfactory with low-flow anesthesia techniques. We use rocuronium and atracurium quite commonly. TIVA can also be considered. Now coming to extubation and emergence from the anesthetic, avoid any form of coughing, bucking, LMA preferred. And these children can be extubated awake with a dose of lignocaine to reduce the effects of extubation. Very important to document the post-anesthesia parameters too. So we need to have a pain relief score when the patient is being monitored. We could also give preemptive analgesia through suppositories, either paracetamol or diclofenac, or IV paracetamol if it is more severe. Avoid PONV, that is postoperative nausea and vomiting. So we avoid nitrous. Limit the use of inhalational agents. Try TIVA or Dexmet. And give pre-medicant dexamethasone 0.25 to 0.5 milligrams per kg. This is how we use the post-anesthesia Aldrete recovery score in the recovery room. It is very structured, very objective, taking into consideration oxygenation, respiration, circulation, consciousness, and the activity. Only when the score is satisfactory, minimum of 9, you can shift the patient from the recovery to the postoperative ward. So you need to document, according to COP8I, all adverse events or complications noticed throughout the procedure and do a proper corrective and preventive analysis. Like I would like to summarize with a few nuggets or take-home messages. Very critical to have a detailed birth history, document associated syndromes, be prepared, aim for a motionless eye, Plan for smooth induction and emergence to avoid any rise in the intraocular pressure. Consider controlled ventilation. Avoid hypercapnia and give antiemetics. Thank you very much.
Thanks a lot, madam, for the comprehensive talk with. I'm sure the acronyms will benefit our residents immensely. Our next speaker for the session is Dr. Paul Williams. He has 2 national and 2 international publications. He is course developer and convener for Ophthalmic Regional Anesthesia Cadaveric Workshop, Sydney Eye Hospital, 2015 and 2019. Over to you, sir.
Can I have the view with my notes? Thanks very much for the kind introduction. This is my first trip to India, and I feel very humbled to be welcomed to join you, and to have this opportunity to present to you is great. I feel a little bit overwhelmed by the quality of all the talks so far, but I'll try and keep the standard up. I'm talking about glaucoma and the anaesthetic implications. As we know, glaucoma is a progressive optic neuropathy. It's associated with characteristic visual field defects and structural changes within the optic nerve head. The intraocular pressure is the primary modifiable risk factor, but at diagnosis the intraocular pressure may be normal or elevated because some patients with a normal intraocular pressure have an optic nerve head that's so at risk that they can suffer damage with a normal intraocular pressure. As we know, glaucoma is is quite complicated. It's classified as acute and chronic, open or closed, primary or secondary. And today I'll be discussing primary open angle glaucoma therapies. Glaucoma is the leading cause of irreversible blindness in patients over 60 years of age worldwide. And Australians have a 2% lifetime risk, with 1 in 8 Australians over 80 years old having glaucoma, and 50% of those sufferers of glaucoma are undiagnosed. And in other countries, this number is much higher of the undiagnosed population. As we know, there's multiple risk factors. Some of the additional ones are a family history, nocturnal hypotension, and obstructive sleep apnea. It's clear that the focus of therapy is for visual independence, and that's through control primarily of the intraocular pressure. It's worth mentioning medical management because it's the mainstay of glaucoma therapy, and it's often combined with and more often than not continued after surgery. There's 5 categories which Dr. Suman kindly covered most of that. Worth noting particularly beta blockers, which can cause bradycardia, hypotension, and sometimes complete heart block, including its other side effects such as bronchospasm. The combined anhydrase inhibitor is the only oral therapy. It's often reserved for severe disease preoperatively leading into surgery, and particularly has more side effects which are worth noting: the polyuria, metabolic acidosis, renal impairment, and also an electrolyte imbalance. Unfortunately, even though these drugs, we have a broad range of drugs, it's been documented that over 45% of patients are non-compliant with their therapy, so they're potentially continuing with the progressive disease, which is worsening their vision despite being in touch with the medical community. Luckily, drug combinations have come into the fore, and this also decreases the preservative exposure, which is irritant to the globe. There's also several regional drug delivery systems which are being investigated in clinical trials in phase 1 and phase 2 trials, and they aim to deliver high concentrations of drug close to the receptors for prolonged periods in a reliable manner. And the addition of also novel drugs coming in, I think a few have been brought in by the FDA in America, and they're the rho kinase inhibitors and the nitric oxide prostaglandin and they enhance the trabecular flow. Trabeculectomy is the most commonly performed surgical procedure for advanced glaucoma, and it was developed in 1968. There's multiple steps and it's quite a complicated procedure. What it aims to do is provide a fistula for the aqueous to drain into the subconjunctival space. There's a wide range of techniques, but over the last 20 years or so, there's been, through the Moorfield's safe surgery system, it's attempts to improve and standardise the therapy in a systematic and precise approach to achieve standardised methods with improved outcomes. And it's designed so that it can be continually improved and adapted over time. The surgeons have quite a range of therapies that they can utilise both in the rooms and in the operating room. One that's worth noting is the tube shunt surgeries. And they provide a tube that drains to a large subconjunctival reservoir. And it's worth noting for anaesthesia because it's a large subconjunctival field that they need to work within, and it's placed behind the superior and lateral rectus muscles, so there can be quite a bit of retraction during the surgery. It's used as an alternative to trabeculectomy when the trabeculectomy failure rate is thought to be particularly high, or if trabeculectomy management has actually failed. Cycloablation is also worth mentioning for the anaesthetic reasons which I'll discuss later, but it's reserved for severe refractory disease, particularly in palliation cases, taking care of pain management. One of the major developments in the last 6 to 10 years are the minimally invasive glaucoma surgeries, or MIGS, and these procedures describe the insertion of a non-biological device or tube which acts to increase the drainage of aqueous either through the normal physiological pathway by bypassing the trabecular meshwork or by bypassing the normal pathway into the subconjunctival space like trabeculectomy or into the suprachoroidal space. They sit on the treatment pathway somewhere between drops and advanced surgery and some of those other surgical techniques. Their ambition is to improve the treatment options for mild to moderate disease and sometimes in the more advanced disease. And also the ambition is to place these relatively simple surgical techniques in the skill set of non-glaucoma specialists. The first available was the iStent in 2012. It's now in its second generation, and it's a 1mm sized titanium button. And now it's presented with a second stent, and those two stents are placed in the infranasal quadrant, usually 3 clock degrees apart, to improve the flow. It's indicated for mild to moderate glaucoma in combination with cataract surgery. Because they're so small, they only cover about 2% of the trabecular meshwork which is available, so they're not very traumatic to the available trabeculum. The third generation is probably going to come out in the next 12 to 18 months, and the idea, we think, is that it might have a third stent and perhaps a reloadable cartridge to perhaps cover more of the trabecular meshwork with those drains. The next is the Hydrus microstent, and it's a titanium flexible alloy. It's made of a material similar to the coronary stents. It's about 8mm long, so significantly bigger. Also placed in the infranasal quadrant, it actually covers the full 90 degrees of that quadrant, and the lumen is about 5 times bigger than the iStent. The company-sponsored COMPARE trial says that the Hydrus had a significant improvement in decreasing drop rates and a similar safety profile, with neither stent showing increased complications compared to cataract surgery alone. The trial suggests that both of these are effective at producing significant reduction in drop use above cataract surgery alone, as I just said. So the iStent and the Hydra simply bypass the trabecular meshwork and therefore use the normal physiological pathway. This provides a little bit of safety because they enter into the episcleral venous pressure and thereby removing the risk for hypotony. It also limits their effectiveness and potential to the mild to moderate disease. And they're inserted in the infranasal quadrant because this is naturally the area of the highest flow through the trabecular meshwork. The Zen was the first MIGS introduced to Australia. It's designed as a standalone procedure or in use with cataract surgery. It's 6 millimetres long, it's a 45 micron gel tube, and it drains the anterior chamber into the subconjunctival space, similar to trabeculectomy. And in doing so, it forms a bleb, and at about 40% of the time, that bleb needs bleb management. It's also aimed at mild and moderate disease, but perhaps is more suited to mild to advanced disease. Over half of the patients with a Zen inserted drop free at about 12 months. The Zen, though, has a similar complication profile to trabeculectomy, even though some of those complications may be lower. The SciPass stent, which is on your far right, is a 6 millimetre flexible stent, and this is the one that is placed into the suprachoroidal space. In its first 24 months, it had showed a lot of promise. It decreased significantly the intraocular pressures, but has actually been withdrawn from the market because of concerns about corneal epithelial decompensation. And the current recommendations from the company are to monitor its position, the corneal health, and the options are either to trim it, but I think people are quite reluctant to remove it because of the space that it sits in, the risk of bleed, of pulling it out of the suprachoroidal space. So the Zen and the SciPass are the two that bypass the normal pathway. So therefore they have a higher potential to decrease the intraocular pressure, but perhaps increased risk of hypotony and increased risk over the less invasive procedures. So then we come to the anaesthesia side of things. Like all anaesthesia, as Edwin referred to, we should be considered in light of the medical history, the medications, the allergies, the orbital conditions, the surgery itself, the surgeon and the surgeon's preference, but also the ancillary staff and the skills of that team, including the anaesthetic team. Anterior local anaesthesia comprises subtenons anteriorly, as well as the techniques that Dr. Eck described, such as subconjunctival local combined with topical, and plus or minus intracameral lignocaine. This is useful. These techniques are useful because motor block is actually not usually required, because you can obtain the positions required by either the patient cooperating or by a corneal traction suture. These techniques, though, they require a fair bit of planning and cooperation, both by the surgeon, the anaesthetist and the staff, and managing the expectations of the patient. And in Australia, I think we have a bit less streamlined than you have here, and perhaps in the UK, where it is a little bit more fragmented and we're working in small places with many different doctors coming and going. So having something like that work effectively all the time is difficult. Posterior local anaesthesia refers to retrobulbar, peribulbar, and posterior subtenons. And all these are suitable, given the usual precautions, and some, though, would argue that they pose additional risk without actual benefit. It's my practice to use posterior anaesthesia for tube shunts and trabeculectomy. It's our preference to use subtenons anaesthesia with conscious sedation, and topical intracameral for those at high risk of orbital complications, such as those with a single eye or those continued on anticoagulant therapy. In my experience, general anaesthesia is rarely required. It's very time and resource consuming, and it presents its own challenges in a population who have a high risk of comorbidities. And you have to be very careful not to increase the intraocular pressure with things such as pressure of the mask, positioning, venous and arterial pressure. Despite these challenges, though, general anaesthesia compares well in the evidence with regional anaesthesia for trabeculectomy. All of the surgeries, anaesthetic techniques can be used with any of the surgeries that I've described. Cycloablation is probably the exception, where general anaesthesia or posterior anaesthesia is required because it's a very stimulating procedure. We know that serious regional anaesthetic complications are rare, but they're probably higher in retrobulbar and definitely higher than peribulbar, and significantly lower with posterior subtenons, and least with the topical techniques. The intraocular pressure rise is higher with retrobulbar than peribulbar, and in the posterior techniques, least with subtenons anesthesia. When treating glaucoma patients with any of these techniques, vasoconstrictors are not advisable, and I find that I need a lower volume than I would in a cataract patient if I was doing a block there. I don't use retrobulbar anesthesia, but I do use peribulbar in the extreme infralateral position, and I top that up with a low medial canthal block using a 25 gauge 25mm needle. It's my preference for low volume subtenons using lignocaine or ropivacaine depending on the case, together with Hyalase for the lower intraocular pressure that causes. We reserve subtenons, subtenons is avoided in those with refractory glaucoma with an eye that it's at risk. And also, we've been considering that the infranasally placed subtenons may perhaps interfere with the drainage of some of the MIGS devices if there's damage to the vessels in that quadrant. I think you have to consider that they take a little bit more time and there's a learning curve for the surgeon, so they'll take more time initially and they'll improve over time, probably down to about 5 minutes additional time, maybe less for someone who's very slick with them. As standalone procedures, they can often be performed just with topical and intracameral, and they're well tolerated, and the companies actually recommend that because pain may actually indicate misplacement of one of the devices. Long left. So, in summary, there's been significant advances in drugs and drug delivery systems with potential for improvement in quality of life. Early diagnosis and treatment is going to be the forefront of actually capturing those people who we don't know have glaucoma and reducing the burden of disease. The MIGS and the techniques and the options are going to continue to improve and advance glaucoma management. And studies do show that the cataract removal alone is beneficial, and also that MIGS improves this on top of cataract surgery. Regional anaesthesia provides good conditions for patients and surgeons, and it should be tailored to the patient, the surgeon and the surgery with regard to the team's experience. I'll just probably wrap that up there. I think in my experience, surgeons will tend to start with wanting more complete anaesthesia, and as they get more comfortable with the procedures, we'll get less and less of that and tend towards the topical and intracameral. There's probably going to be more of the MIGS standalone procedures, which might even be done in rooms. And really all we'll provide is anxiolysis for those patients. I think the surgeons will be able to do those standalone procedures, particularly on the non-invasive procedures, on their own. Thanks very much.
Thanks a lot, sir, for the excellent overview on recent advances in glaucoma surgery and anesthetic considerations. Our next speaker is Professor Renu Sinha. Professor Renu Sinha is professor at All India Institute of Medical Science, Delhi. She is the professor at Department of Anesthesiology, Pain Medicine and Critical Care. Her special areas of interest are pediatric anesthesia, ophthalmic anesthesia, regional anesthesia, ultrasound-guided nerve blocks, difficult airway, obstetric anesthesia, bariatric anesthesia, intensive care, kidney transplant anesthesia. She has various publications and she has authored various chapters in several books, and she has presented in various national and international conferences, and she is a recipient of gold medal in obstetric and gynecology in MBBS, and she has received AIMS Excellence Research Award in the year 2014. Madam will be speaking on anesthesia and squint surgery. Over to you, madam.
Very good morning to everyone. Topic of my talk is anesthesia for squint surgery. I am dealing with children only today. So, among the ocular disease, strabismus covers half of the patients who are coming for surgery. It has been seen by Duclos et al. That in 6 months of the survey, they saw that 50% of the patients are for squint surgery. This is not working. In our center, that is RP Center, we are a tertiary care hospital, and in 1 year, we do roughly 3,500 cases for pediatric squint surgery, which include 1,500 pediatric and 2,000 adult patients per year approximately. It may be more than this. The incidence of squint surgery is around 2 to 7% in children and usually present between 1 to 4 years. The surgery should be done as early as possible after the 6 months, and usually it should be done before 5 years because of the complete maturation of the visual axis. In this surgery, surgeon repositions the insertion point of the extraocular muscles with a goal to avoid amblyopia, to improve depth perception, to eliminate diplopia, and to provide a cosmetic correction. Before the start of the surgery, force duction test is usually done to test the range of the extraocular muscles motion and also to distinguish between paralytic and mechanical restrictions of the muscles. Because of the force duction test, one should avoid the succinylcholine because it causes the prolonged depolarization and muscle contraction, which can be there for as late as 20 minutes and which can lead to false results of the force duction test. So if an anesthetist is giving succinylcholine, he should inform the surgeon that they should test the muscle with a caution. As 50% of the patients coming for squint surgery are healthy, but another 50% of the patient may have one or other comorbidities like congenital heart disease, craniofacial syndrome. Mostly they are coming with patients who are having syndromes, Down syndrome, Crouzon syndrome patients. Obesity is also there in many patients, such as Prader-Willi syndrome patients. Patients with neurological disease such as cerebral palsy, hydrocephalus, they are also coming for this squint surgery routinely. And the patients who are having myopathy, they should be dealt with caution. Some patients who are having attention deficit hyperactive disorder and mentally subnormal, they are also difficult to handle once they are coming for the squint surgery. The major concerns for squint surgery among all ophthalmic surgery is high incidence of OCR, high incidence of PONV, and post-operative pain. It has been seen that the patients who are having squint surgery have high incidence of malignant hyperthermia or masseter muscle spasm. Although it is controversial, it was said that in initially 1970 and 80, the incidence is more, but now it has been said that it is not more than the normal population. But recently, an article published in JAPOS in June 2019, which showed that there was a suspected anesthesia-induced rhabdomyolysis in a child who had undergone strabismus surgery. This girl was 11 years old, and for the anesthesia, sevoflurane, succinylcholine, and glycopyrrolate was given. The child had tachycardia, tachypnea, and high EtCO2 in the range of 68 to 71. Surgeon informed that he is not able to do FDT, and after 5 minutes, he was able to do FDT. Intra-op was otherwise uneventful apart from tachycardia and high EtCO2, but in the post-op period, patient had tea-colored urine, and it was seen that there was markedly raised creatinine kinase. Although after 1 week, patient was all right, but these cases can happen. And the mainly trigger factor is succinylcholine in this case. Among the pre-anesthetic checkup, this is just like any other pediatric patient, but one should see the comorbidities and family history of any other disease along with the risk factor for post-operative nausea vomiting. Anesthesia goal, just like other ophthalmic surgery, there should be avoidance of OCR, control of EtCO2, and prophylaxis and treatment of PONV. Once we talk about pre-medication, we should think about OCR and PONV. So midazolam decreases the OCR and PONV. Ketamine also decreases the OCR and PONV. Recently, we started using dexmedetomidine, but it can cause decrease in the heart rate, but it is very beneficial in reducing the pain and emergence delirium in the post-op period. Initially, people used to give anticholinergic in all the cases for squint surgery, but now it has been debatable that prophylactic anticholinergic should be given as a pre-medication in squint surgery patient or not. In induction technique, sevoflurane or propofol can be used. So it's usually anesthetist choice to use inhalational or intravenous agents. For maintenance, inhalational agent can be used, and TIVA in the form of TCI can also be used. A paper recently published in 2012 in which they did the awake, sleep, awake technique in children for strabismus surgery. This is mainly done to decrease the over or under correction of the squint. And in this, they have used TCI with the propofol in both the groups and sufentanil and remifentanil. All the cases were done uneventfully, but they have found that remifentanil causes quicker wake-up time because patient had to be waken up in between the surgery to see the correction, and then afterwards, again, the anesthesia was given with the propofol or sufentanil or remifentanil. So in the remifentanil group, the time was quick, but with the sufentanil group, analgesia was better and the hemodynamics were better maintained. We usually induce the patients with inhalational agent with the presence of parent with the sevoflurane anesthesia. If we talk about airway device, particularly for squint surgery, then as for all other ophthalmic surgery, the supraglottic airway devices are better because they provide stable circulation and less airway stimulation. But for the squint surgery, we usually prefer flexible LMA or AirQ LMA because flexible LMA can be taped at the chin so that there will be no protruding thing and it will be at the level, drapes will be at the level of chin. With the AirQ ILA also, we had this custom-made device. So now again, drapes are not protruding because it is necessary for a squint surgery as the surgeon's hands are there towards the chin side also. So if anything which is protruding above, it can cause hamper for the surgeon's movement. So flexible LMA and AirQ ILA are better if we are using a supraglottic airway device. In AIMS, usually surgeon says if you cannot put both the device, then put endotracheal tube because they don't want to do surgery with this device. The most common incidence of oculocardiac reflex is seen in squint surgery. This is 20% decrease in the heart rate from the baseline, but it has been seen that in different studies they have used the definition in a different way. Some says 10% and some says it is 30%. The incidence can be as high as 90%, and it is more severe and quick if there is abrupt or sustained traction on the extraocular muscles. And as we all know that it disappears after the discontinuation of the stimulus or if repeated stimulus is given. OCR is a trigeminovagal reflex. So the origin is from ophthalmic division of trigeminal nerve, and efferent is vagus, which causes so many types of arrhythmias, even asystole. Factors which can reduce the OCR are studied too much. So it has been said that lighter anesthesia, hypercarbia, hypoxia, halothane, and remifentanil will cause increase in the OCR. And as I told that ketamine, midazolam, and anticholinergics, they decreases the OCR. And among muscle relaxant, rocuronium has been shown to reduce the incidence of OCR. If we talk about inhalational agent, newer inhalational agents, just like sevoflurane and desflurane, they have no effect on the OCR. And the type of ventilation, whether it is spontaneous or controlled, they have no effect on the OCR if you maintain the normocarbia. So prevention can be done. You can tell the surgeon that he should communicate before the manipulation of the extraocular muscles. There should be gentle manipulation. Anesthesia should be adequate, and if one wants, then they can put the BIS, but the surgery is around half an hour, so many time putting a BIS will take another 10 minutes. So it is used in patients who are having more problems. And as I said, prophylactic anticholinergic, it is debatable to give or not. In our place, we usually keep the volume of the heart rate a little bit high. So surgeons, they are used to listening the heart rate, and as soon as they found that there is a decrease in heart rate, they leave the muscle and they put the topical anesthesia. Treatment, as we know that release of stimulus, then ensure adequate depth, and it has been seen that topical anesthesia and regional blocks, they are very beneficial in reducing the incidence of OCR. There is one paper in 2018 which evaluated the surgical factor which affect the OCR in squint surgery. They studied 162 patients and they noticed that the first operated muscle has more incidence of OCR, maybe because there is fatigue. And resection surgeries and the medial rectus surgeries has more OCR, but in other studies it has been said that the muscle itself is not a contributing factor for the OCR. They have also noticed that there is, once the OCR occurs, then the heart rate will not come to normal until there is cutting of the extraocular muscle is there. Another paper I found which was very interesting, that infratrochlear nerve block also reduces the incidence of OCR, and it has been seen that mostly medial rectus is the responsible for the OCR. So they gave the injection at the medial orbital rim at this place, 1 ml of 2% lignocaine, and they have seen that in the group in which the nerve block was given, there is less incidence of OCR in comparison to the other group where nothing was given. You can see at the time of muscle dissection, the heart rate went below 80, and incidence was 87% in the control group, but in the block group it was 20%. So it can be used as a method to reduce the oculocardiac reflex. In squint, there is another reflex which is seen mainly in patients who are on spontaneous ventilation, that is oculorespiratory reflex. Has the same efferent pathway just like the OCR, but the efferent pathway is through phrenic nerve. So once it occurs, there is decrease in the tidal volume and respiratory rate, which causes hypercapnia and hypoxia, and again, both the factors can increase the OCR. So PONV rate is very high, up to 42%. It can lead to dehydration and delay in the discharge. So there are other risk factors apart from squint surgery which should be seen, just like opioid, gastric distension. There's oculoemetic reflex which causes the increase in the PONV. And also it has been said that the alteration in visual perception post-operatively is another cause for PONV. And it has been seen that posterior fixation of muscle, because there is too much handling of the muscle, it increases the incidence of PONV. So the prophylaxis, we all know that these are the drugs which are used. Mainly 5-HT3 antagonist and dexamethasone are used for the prophylaxis and treatment. Other methods are use of hydration, no force oral intake, then acupressure. It has been studied that effect of FiO2, but there is no effect of FiO2 on the incidence of PONV, and nitrous use is also debatable. Some studies say it increases the PONV, but others say that it is not increasing the. So once we talk about the inhalational versus TIVA for PONV, it has been seen that if TIVA is given with L-fentanyl and nitrous oxide, there is some increase in the PONV in the inhalational group, but simultaneously there is bradycardia which has been increased in the TIVA. So you have to be careful to decide whether to use TIVA or single or inhalational agent. Another study, this study said that sevoflurane is used for maintenance or remifentanil is used for maintenance. There is no change in the incidence of PONV, and remifentanil causes the significant decrease in the heart rate during the surgery. This meta-analysis showed 13 RCT with 2006 patients, and they recommended the combination of dexamethasone and ondansetron should be used in squint surgery to reduce the PONV. We did a study on granisetron versus granisetron and dexamethasone, but we did not find any benefit of addition of dexamethasone to the granisetron to prevent the PONV. This is one interesting study which was published in 2019. They did the 4-year quality control study in the strabismus, and they had found that from 18% of the PONV incidence, they were able to reduce it to 4.72. So they made a strabismus toolbox. Preoperatively, the painkiller was given. Intraoperatively, they changed fentanyl to morphine or hydromorphone. And in the for the PONV, 2 drugs should be combined, and LMS should be removed in a deeper plane. Postoperatively, the pain is for pain, morphine or hydromorphone is given along with the ice compression and distraction. Regional blocks also have a good effect on the prevention of PONV. For the postoperative pain, it has been seen that squint has postoperative pain quite common than the other surgeries. Opioid is used, but there is debatable thing that it increases the PONV. Blocks can be given along with the topical and NSAIDs. A study from our place showed that subtenon block does not improve the analgesia, although it reduces the incidence of OCR and PONV. Just I will take 1 minute more. Another study which showed lignocaine 2% gel with the proparacaine drops, and it showed that the pain is reduced once the lignocaine gel was used at the place of proparacaine eye drops, although OCR and PONV was not affected. This study also showed that topical oxybupropivacaine reduces the pain score in squint surgery in comparison to fentanyl. Extubation should be smooth and patient should be in lateral position. In PSU, it is debatable whether to patch one eye or both eye or none. PONV and pain should be treated. Emergence agitation can happen in the post-op period, maybe because of the eye patch, because the child is anxious. Midazolam can be used for this. So to conclude, squint surgery is a common surgery for ophthalmic point of view. One should try to use supraglottic airway device and try to give prevention for PONV and pain. OCR should be controlled by one or another way because different studies will tell different things. So maintain your own protocol according to your practice and choice. And you will get happy child at the end with a corrected eye. Thank you.
Okay, so it's a great pleasure. My title is not quite as it was noted, because we use hypnotic techniques not only on cataracts, but also on all kinds of ophthalmic anesthesia. And I want to show you how this blends in with the technique. Most of you are old enough to know what revolution balanced anesthesia was. Now, as we're barging on into uncharted territory with older patients, balanced anesthesia may not always be the choice anesthetic procedure, and I would argue with you that maybe multimodal general anesthesia, as it has laid down in this wonderful review by Emery Brown, and hypnosis is just, in that case, hypnosis is just a part of trying to spare general, to spare opioids, to use other drugs, and to monitor the EEG. So there's a long history, and it even goes back to the Rig Veda, where the Princess Sukanya performed a bilateral enucleation with a poking stick on the Maharishi Chavana. And this story only has a happy end through the interventions of the Ashwins. I think we all want to assure the help of the Ashwins, but there's other strategies to go by. If you know Ramon y Cajal, he's really one of the eminent scholars in neurology, and he found a way of using hypnosis as an anesthetic ailment when his wife said, honey, we're having 4 children. I'm not going into another series of birth pangs. So if you can come up with a good solution for that problem, we will have a marital life otherwise. So he found a good solution, and the solution was that good that in Barcelona at the time he was overrun by women in labor pain or preparing to go into labor. And Charles Esdale, he was a surgeon in Calicut at the time, well, of the Raj, and he had enormous success using the then modern mesmerizing techniques. And if you just give it a short glance, if you're used to looking at raw EEGs, this is a young colleague, and she learned hypnosis in one of our courses. And at the time, she was in intensive care, and she really had quite a wrecked up sleeping rhythm. And she said, I can't go to sleep, Friedrich. And I said, just try to use this. And she used the techniques that she learned. And if you look at this is, so if you would have a propofol remifentanil anesthesia going, you would probably reduce the dose, either by this index or by the raw EEG. showing spindles and delta waves, or by the spectrogram. The only thing is there's no drug in that brain. It's just hypnotic technique. So we have objectifiable substrates for what we do when we give hypnosis, and there's more and more literature coming at us that shows us fMRI substrates for these neurologic techniques. So this was a study from the eminent Liège group in Belgium, where they tested pain impulses in increasing intensity administered by laser on the hand. So this was low intensity. You see these red spots, that's a substrate for pain. And under hypnosis, these do not surface. So one of the idea is that during hypnosis we can kind of increase the gating function of the thalamus to not admit pain or nociceptive impulses to the cortex. So this is what hypnosis is not. Hypnosis is just a technique that you guide your patient through. It's nothing paternalistic. You just tell the patient, or what we usually do is we say, okay, so I see you're frightened. Just take a deep breath. I mean, anapanasati is a technique that everybody I think here knows. We just guide them to a reduction and a deepening of the breath, and we try to keep their focus on the last holidays, on their favorite place, and take it from there either to a little more sedation or into GA. And it works quite well. So just one of the arguments why it might work, there's a lot of evolutionary, well-preserved strategies by animals to feign death whenever they come under pressure or a menace. And these substrates, it's not well visible, but they kind of relate to what we see. So no matter what anesthesia you're doing, there's this triad you work on as the cognitive concepts. Any anesthesia trainees can reduce wakefulness by gas, by propofol. And there's these distinct cognitive contents that we want to reduce, either pain or anxiety, and that's quite a problem in ophthalmic anesthesia. And the other thing being, we want to dissociate the patient in a way that he does not realize what's going on. And this has surfaced in many of the talks before. We can do this by hypnosis or by ketamine, and the interesting thing is that in fMRIs, the cortical zones that are activated either by hypnosis or by ketamine are the same. So there's a lot of literature coming at us, and this is an interesting study from Paris. You can go and look at the video. What they actually did was open skull surgery and hypnosis, and you may cringe at the imagination, but the interesting thing is that a vast majority of the patients would say, yes, I would undergo awake craniotomy in that very mode. So another important issue with our patients is that we're up against a lot of neuroinflammation, and there's a direct correlation to postoperative delirium. This is a very interesting case, a tragic case. This woman, 55 years, on the birth of her first child in an emergency cesarean, suffered awareness with recall. It was extremely traumatic for her. She realized while she was in severe pain that the baby was born deaf, that it was resuscitated, transferred to another hospital, and she had post-traumatic stress disorder, severely sleep deprived herself because she could not undergo the moment going into deep sleep, and when she needed to come, she was utterly panicked. So she said, "Doctor, I need you to help me with this. We need hypnosis." She knew something hypnosis, and she chose her own music, so we played the music to her, and we had the safe place imagery for her, and she just gave me a wink with her finger when she said she was ready. Again, what you see here, and this is coming more and more in my presentation, what you want to see is not the stupid index, because it is going to fool you with BIS, with Narcotrend, no matter what. Once you curarize for whatever necessity, the index goes down. It does not reflect anything about the cognition or the consciousness. But what you want to see is these spindles which reflect corticothalamic oscillations that are impervious to impulses coming from the subcortical structures. So, going back to the hypnosis, it seems in this prospective randomized study that this tablet is much better than benzodiazepines in many endpoints, like separating from parents, like pachydelirium in children. And we've also seen this. I mean, some patients, like this poor chap here, why should we separate him? He's a glaucoma patient, he's coming in and out, he's extremely anxious, and we always have mom in bed with him. And when we induced him with SIVO, we had some of these theta waves, and he came round under propofol to a nice EEG. Avidan, he's one of the foremost scholars in preventing cognitive complications, and our furthermost aim, especially in children and our old patients, is that we want to keep them on this trajectory of cognitive decline without going here in the postoperative delirium. If you remember, then these are the EEGs of patients with old drugs like ether. And it seems that one of our main problems is not awareness with recall, but oversedation. And there's a direct correlation of oversedation to perioperative delirium and cognitive decline. And if you want to see these EEGs, you have to go to the intensive care ward where the most severe coma patients lie. If you take a look at general anesthesia from a sleep medicine glance, then studying the EEGs tells you about the motives that you see, because nobody wakes up in the morning and is delirious. Nobody wakes up in the morning and has post-sleep nausea and vomiting. It just does not happen. So there is more and more literature coming at us that tells us if we go for these motifs, like in this general anesthesia, we get better results. I think one message that we need to take home, especially comparing these EEGs, that the brains of our patients are not computers that we reboot while the surgeon is doing his work. And it all comes down to some disconnecting of cortical-thalamical connections, and in tune with what we see when we play music of own choice. Any patient, any old patient, no matter if his GA was 2 hours long, 3 hours long, when I go to post-medicate him, says, and just 2 weeks ago I had a 100-year-old lady say, "Oh, you are the guy who played Mozart to me." So they know this. They memorize this, and it seems that it helps to stabilize the network resilience. This is an interesting study talking about these very spindles. And it shows that the proclivity to go into postoperative delirium, if you take somebody on this trajectory from a deep anesthesia directly to awake, is much, much higher than if you go through stages like the brain does in non-REM sleep. So if you go from delta dominant, deep anesthesia, through spindle dominant, you can break the correlation of old and demented to postoperative delirium. Dexmedetomidine, you've heard a lot of it. We use it a lot. Every patient gets a bolus. Children get intranasal. It really helps. So there's another thing that we will have to take into account more and more, and this is how is our anesthesia embedded into the sleep architecture of our patients. The older and the more visual impaired, the less good their sleep is, and this increases the likelihood of cognitive dysfunction. And if you choose your drugs for anesthesia, you need to choose drugs that will help the patient recover from their sleep debt. So here's a point for using Dex, as it is a biomimetic sleep drug, together with propofol, as we do, and maybe avoid halogenated ethers in sleep-deprived patients. So this is our Betty Crocker recipe for the old and frail. We start with sedating Dex. We nearly always combine a subtenance block with an opioid-free general anesthesia. We dumped benzos altogether. The aim is to reduce opioids, and the doctor should be an anxiolytic. no matter how stressed you are in the high turnover, you lose if you transfer your hectic to the patient. You can use different hypnotic techniques. If the patient gets to choose his own music, that helps a lot. Then, if anyhow possible, use a laryngeal mask. You don't have to over-sedate or sedate away the tubus itch. I think if we have the possibility, we should monitor EEGs. I use a lot of ketamine, and there's another thing that you can discuss with your surgeons. There are phases in surgery where there's absolutely zero tolerance for movement, coughing, retching, and so forth. But no harm is done if the patient retches or moves a little while conjunctival sutures are being done. Defining these phases helps you to have a patient at a not as deep level and to work actively against oversedation. So, just this patient took a siesta, took a siesta before she fell asleep, and it's the same motifs here, more or less, as here. The spindles are there. This is a teenage girl, and she was very scared because she needed to have an eye puncture. And we all have the experience, if a child goes in anxiety or in unrest, it comes out in unrest. I think you most can relate. And she had these questions, and although we had her parents, she took her own music, she was panicked. And I was panicked too when I induced her with SIVO, because I thought that with these theta waves, she would maybe even go into an epilepsy, which thank God she didn't. And once we had the line in, gave her propofol and Dex, she did these wonderful spindles and deltas, and she came out in perfect bliss. There are more and more signatures that maybe pain might be coming through. And this is kind of cutting edge translational research, because we always have to ask, apart from the big numbers, why do things work and why do other things not work? And it's only 2015 that it was found that the brain has a lymphatic system that tries to remove all the metabolic gunk that accumulates. And this system is especially working well in natural sleep when we have delta waves and spindles. And in rats, choosing a certain cocktail either impedes the work, isoflurane, for example, shuts down the lymphatic system, and ketamine and xylazine in this case, and Dex kind of increase the drainage. So to summarize, or just to finish here, I think we live in a very thrilling age with such a lot of knowledge coming in from the cognitive neuroscience and from sleep science into our field. I think we should not shut us up against it. And in the words of Eric Kandel, the Nobel laureate for neuroscience, the biological studies of the mind offer the possibility of a new humanism that also we as anesthesiologists can live in. And that is one that merges with the science, which is concerned with the natural world, and the humanities, which are concerned with the meaning of human experience. Thank you.
Thanks a lot, sir, for an excellent overview on a novel technique. It was overwhelming to know its roots from our Indian scriptures. With this, we come to the end of the second session. We can take a few quick questions over to the moderators. I request the speakers of the second session to come onto the stage.
Thank you to all the speakers. It was a very excellent session. I have a lot of questions if the moderators allow, but at least one or two questions I have to clarify. The one is for Suman. The pre-assessment, what you have talked, can you include the Brasilos tape in the pre-assessment? Because I've seen many times when we are anesthetizing a patient, and we roughly take according to the age or weight and all, and finally when you take that drug or the equipment, it doesn't particularly match. So we are trying to implement the Bracillose tape in the ORs and in the preoperative PAC rooms. So do you suggest that it will be a good idea for us to implement? Bracillose tape, I think.
I do not have experience with that. I would like you to enlighten us.
Yeah, Bracillose tape is nothing but a tape which you can measure the length of the child, especially for children, and at the, if the length ends in the red color, all the equipment, the what you call the laryngoscope blade, the drugs, midazolam, ketamine, whatever drug you want, it is there on that red colored area. So I think it should, because I have come across many of the patients where we thought that 5 millimeter endotracheal tube is a perfect size, and when we introduced that, the patient later developed some edema or something, which we felt that is not the correct way. So Bracillose tape may help in these things, sort of thing.
Okay.
I think there are many people who have come from different countries.
For the endotracheal tube, you always have one size smaller and one size large endotracheal tube in your equipment once you are dealing with the pediatric patient.
No, actually what I am trying to tell is we have taken the correct size endotracheal tube, but when we have introduced the endotracheal tube post-operatively, we face that problem. So I am thinking that Bracillose tape may be a better option to be introduced into the ORs, so that the exact, I'm not just talking about the Bracillose, that endotracheal tube, I'm talking about the medication also. It gives the exact amount of drug that has to be given and all, at that particular height of the patient.
I think drugs are not made for the height of the patient, they are made for the BMI, and you can see that if the patient, sometimes nowadays the obesity is so common, a child who is 4-year-old is weighing 35 or 40 kg. So that the length is not increased, the width is increased. So only height cannot decide about the exact amount of drug or the endotracheal tube size. Endotracheal tube size is always taken as from the weight rather than age, from the age rather than the height. Height is mainly used for the fixation of the endotracheal tube at the corner of the lip rather than for the size. And frankly speaking, in ophthalmic surgery now we are using 95% we are using supraglottic device, and in endotracheal tube also we have not found that increased edema in patients. Maybe sometimes for other reasons, maybe the tube is too large for that patient. Once you are introducing an endotracheal tube, you will have that idea whether you are using cuff tube or uncuffed tube for the patient.
I'm talking about the plain tube, uncuffed tube. It was a plain tube. 2 or 3 incidents it happened. Anyhow, I just gave a suggestion. I'm not telling that it is. I thought that because the Bracillose tape doesn't cost much, it hardly costs 2,500 rupees, where the emergency medicine people.
Maybe we can do the study and see that it is helping.
So nobody has a question. Can I ask one more question? It's for Dr. Renu Sinha. You told that when you are doing the surgery, for splint surgery, you can give the block to reduce the what you call oculocardiac reflex. Can this block be given after they start the surgery? They have doing the surgery, and then they found that the bradycardia is not controlled with all the medication. Can they give the block?
Sir, actually, I found only one study for this block, and they had given before the start of the surgery, especially in those cases where medial rectus was involved. So this was one study only I found. I cannot say, because in my place they don't give intratrochlear nerve block. So I have no personal experience. We usually give subtenon block if there is OCR is happening again and again. Otherwise, prophylactically, for the few theses we had given, the surgeon is not very happy at my place to give subtenon block before the start of the surgery. They usually give at the end of the surgery. But in some patients, if OCR is happening again and again, then they give. Yes, sir.
Using blocks in the children itself is very controversial, because you have to weigh safety versus benefit. You understand? So blocks cannot be used so easily in the children as they are used in the adults.
Sir,
Just for the purpose of oculocardiac reflex, I don't think it is any study recommends to be used it prophylactically or prior to the surgery.
Excuse me. So I just wanted to say a few words on the Brocelo tape because we did a study around 3 years back at Indira Gandhi Institute of Child Health under Dr. P.M. Chandrasekhar. The Brocelo tape is actually a tape that is used in emergency where you cannot weigh the child, where the weight for height or rather the weight for length correlation is given, and when you turn the tape, every drug's dose is given, as well as all instruments, endotracheal tube, Foley's, intercostal drain, the Riles tube, all these measurements are given. So it is a tape to be used in the emergency room rather than in the operating room where the child is too sick for you to weigh the child and you do a weight for length correlation. For children coming for ophthalmic procedures, we can actually measure the weight as well as the length itself, or the weight or height if the child is able to stand. So that's just this word.
Sir, just about the block. Day before yesterday, I was talking to my surgeon, Dr. Pradeep Sharma, about the subtenon block, how comfortable he is. He was very reserved for subtenon block. He said that because you people are doing thesis, that's why I am giving. Initially, the chief guide used to say that give 2.5 ml of block. Then he said there was conjunctival edema and the things are not good. Now they are giving only 1 ml of bupivacaine or ropivacaine for subtenon at the end of the surgery. And in some patients who are having OSA or other syndromic patients, we insist them to give before the start of the surgery because we are not giving opioid in those patients. So only in those special cases we give subtenon before the start of the surgery.
Maybe just a remark. We also do it with 1 milliliter. And I think one factor that needs to be factored in is once you kick off the OCR and once you give atropine going through the brain, the incident of PACU delirium with children is increased. So if the surgeon opens the tenon space, which he does to just isolate the muscle, 1 milliliter of injection is really not much of an investment. And I think you reap a lot of benefits for your children.
And even the dose of atropine is also reduced. Initially 20 mg per kg. Nowadays we are giving 5, sometimes 10 mg per kg for the OCR. But mostly need for atropine is very less. Only 2 to 3% of patients you may encounter. Because surgeons are so experienced and so used to, they are not manipulating the muscle in that much amount now.
Suman, how many of them are using isolate P now in the, because nowadays they say that isolate Ps should not be used because of the hyponatremia. But even still in our hospital also we are still using isolate P. It has become very difficult for us to remove the isolate P and bring ringer and all. So I don't know how many of the practicing people are using isolate P.
Yeah, it's more of a habit, I guess. But then once we look into the literature, they say it's really, it is a debatable issue. So it's probably what the anesthetist is more comfortable with. But I guess even nowadays just crystalloids are being preferred. And only when indicated, I mentioned in my talk also, when there's specific history of having a diabetic mother or hypoglycemic attacks in the past or something, if there's something very specific in the history, during history taking of the baby, then probably you can use it. Otherwise, you can probably just stick to the crystalloids.
I think with this...
Yeah, congratulations. We really loved the lectures. My question is to Dr. Fred. In one of your slides, you had mentioned, you had shown pain on a CT scan as normal sleeping pattern, the red spots, and below that they were, when the patient was hypnotized, those red spots disappeared. My question is, what happens in sleep? Do they disappear in sleep?
Well, that's a difficult question. So these were just on awake patients, hypnotized, suppression of pain in awake patients. I think the question should be framed otherwise. If we use hypnosis or meditation, whatever, before we take somebody to sleep, the increase in delta power and these spindles that I show you, do they linger on or not? That is the quality. Because once we have the spindles, we have the cortex and the thalamus are kind of dancing with each other. And if the pain stimulus comes from the subcortex, it doesn't go through. And reverse, if we lose the spindles, I had to skip that slide. If we lose the spindles, if we lose alpha waves, that is a pretty good sign that pain is coming through. There's very good work from the Rebecca Slater group, Patel group in Oxford.
They give one block, they start that surgery. After completing that eye, they give the block intraoperatively for the second eye, and then they do the surgery. So not simultaneously, but there will be around 20-25 minutes gap.
But in many of the institutes, they are still giving bilateral back at the same time. They are doing
No.
both eyes and
Okay.
they are giving the block. In many of the institutes, they are following. It's not a good practice, but they are following.
I suggested them that you can give Subtenon for the second eye, but they are not very comfortable. They say once you give Subtenon, there is fluid is going towards the muscle also, and the precision of the cut is not there because of the edema which happens because of the Subtenon, and they cannot wait for that much time to edema to go, because one muscle means 10 to 12 minutes surgery. So if they wait for that, then they are not doing that much of cases. So practically Subtenon, till now I am not able to convince them to give for the surgeries, even for the cataract surgery which they give peribulbar, or for any other surgery.
I think we are running short of time.
Sir, question for Frederick, sir. Sir, what's the time difference between the hypnosis, taking hypnosis for surgery and taking pre-op medications for the surgery? I want the pre-operative